segment of the program. But before I invite our guest today, who is already well seated, I'm sure you would love to listen to her. I think last week we had a great lady, and this week again, we'll definitely be listening to another awesome, fantastic, and brilliant woman. But before she comes to take the next some 30, 40 minutes to make her presentation, let's remind us or refresh our minds about some of the activities of the agency in the past week. That comes in our news highlights segment.
The Niger State Command delivered an advocacy lecture to students and teachers of Al Nara Islamic School, Mina, while the Kano State Command delivered the same lecture to students of Government Commercial Secondary School, Wudil. Still on Tuesday, the Zamfara State Command paid a wider advocacy visit to the State Governor, His Excellency Dauda Lawal, at Government House, Gusau. On Wednesday, 8 November, the Oyo State Command delivered a wider sensitization lecture to students and teachers of Community Secondary School, Idiape, and the Ebonyi State Command also on the same day sensitized students and staff of Junior Model Secondary School, Afikpo, on the dangers of drug abuse. Continuing the wider activities on Wednesday was the Directorate of Seaports Operations, which facilitated sensitization lectures to two schools, namely Akandeda Hunsi Memorial Senior and Junior High School, as well as the Ilado Community Junior and Senior High School, Ikoyi. Not less than three schools received wider sensitization lectures on Friday, 10th November. The schools include Premier Grammar School, Abeokuta, Ogun State, Ofedepe Comprehensive High School,
I'll make contributions in few seconds. Please note again, let's try as much as possible. Go around as many people as possible.
So it causes a lot of delay, even when people talk to them about going to the hospital and all. But because of that deep-rooted belief that mental illness is a spiritual, has a spiritual basis, it hinders them from going to seek healthcare. Now, another factor not too far from this is stigma. We have self-stigma, we have stigma from society, where people treat those who have one mental illness or the other in a certain way that excludes them from society. It excludes them from enjoying the basic rights or the basic amenities that is human rights. And so because of that, people don't even want to, express themselves when they have any mental health challenge. In fact, it's as serious as some families, when they have family members who have one mental health challenge or the other, they hide them and then just talk about everybody keeping quiet about it. So stigma is still a very, very significant problem. I mentioned self-stigma, where there are some mental illnesses that may not be so obvious to others, but the person feels the symptoms, is in distress. And so that they are not labeled mad or a lunatic, they find themselves just hiding it away from others. So that in itself, that individual finds themselves even stigmatizing themselves. So these are some of the things that cause people not to be able to access healthcare facilities or mental health care. Another major problem is the availability of this mental health service. Okay, so let's say there's a better understanding, nobody is bothered about stigma. How about the issue of this mental health service? Are they even available? Now that takes me to talking about treatment gap. Treatment gap is essentially the difference between those who are in need of this mental health care and those who actually get it. So in recent times, it's been estimated that the treatment gap in Nigeria is about 90%. So let me bring it home. It means that out of 10 people who need mental health care, only one of them gets it. So it shows that the service is not even as available as it should be. Now, remember that we are coming from talking about how large the population is, how many people, estimated would need this mental health service at one point or the other. And this is us now saying that 90%, the treatment gap is 90%. So let's just say that 90% of people who need this healthcare service eventually don't get it. Now, some of these issues that has to do with availability of this service is that infrastructure. Now, maybe because we live in an urban place, in an urban setting, but even though we live in an urban setting, how many government facilities offer mental health service that can serve the population in this area? Let's go to states that may not be as developed as Abuja. There was a client that I saw some days ago who was going back to, forgive me, I'm going to mention specific states so that it can, sink home, was going back to Adamawa. And the question was, okay, how would she continue her care over there? And then I got to find out that, there's no mental health service that is properly established in Adamawa. You can imagine in a whole state, even if they have someone who visits, I would even classify that individual as half, because visiting is not someone who is dwelling in there and can be available at all times. Let's even say is one person that there's someone there who is available. How can one personnel be available to, serve that whole population. So availability is both infrastructure and the human personnel. So we see that in some states, they don't even have a proper mental health service. In the government hospitals, some mental health departments are not as functional as they should be. Even if they are functional, they don't have enough personnel that can serve the needs of the people. If they need admission, not so much. In the state where I did my residency, the teaching hospital, they had maybe collectively male, female, had 10 bed space. Imagine a teaching hospital having just 10 bed space for admission, male, female, old, young. And this is a state that has over a million million inhabitants. So we don't have enough infrastructure, we don't have enough personnel. And recently, we are aware of the export of intellectual properties these days, a lot of brain drain. So you have even the few personnel that are available going out of the country, and then those who are supposed to now, go into training, we don't have so many of them anymore, because for fresh graduates, what they are thinking of is, let me go out of the country. So they are not even settling in Nigeria to have the training done. So I could go on and on and on with regards human resources, but I hope this paints a picture as to how much vacuum that we have. Some places where you even have facilities, you have the personnel, medication becomes an issue. Some medications are very expensive, which maybe initially the patients can, start taking and feel better, but are not able to sustain because the cost of buying these medications are too much for them. Now, I had mentioned this earlier, but I want to, buttress on it a little bit, which is with regards accessibility. If we want to scan through, just do a mental scan of the country, in the places where you have mental health facilities, they are mostly in the urban area of the state, meaning that people who stay in the very local, rural areas have to travel all the way to the urban area to be able to get help, which is not everybody that can afford the cost of travel, the cost of accommodation when they go, and all of that. Meaning, even if you have mental health facility in a state, it doesn't cut across, the whole state. Those who are staying in rural areas are they are not able to enjoy this service that is available. And then if you have ever traveled to rural areas, you know how tortuous their roads can be, how rough and all of that. So commuting to urban areas may not be so easy. And then in places where you have a fair number of facilities, where maybe private services come in to compensate for the insufficiency of the government's facility. These services are very expensive and are not available to not just the low class, even the middle class. It is not affordable for them. And then this becomes a major barrier in people being able to access mental health. And if we look at the HMOs, the health management systems that we have now, the health management organizations, they do not, most of them do not cover mental health in their insurance. Those that you see that cover mental health service, they are premium, so they are not even accessible to the average person. So HMOs have not even made it any easier in accessing mental health services. Now, let me just talk a little about the challenge about substance use. I'm so, happy about what the NDLEA is doing, trying to, clamp down on the activities of drug barons and drug peddlers, because this is also a major cause of mental illness. So one of the major problems we have is that availability of psychoactive substances on the streets has made it a lot, it has made the prevalence of mental illness to also increase. So that's another major problem that we have. We have, peddlers all over the place, and people are getting more and more hooked on it. And that is a major problem. So, having highlighted a few of the problems, there are a lot more, but so that it's not all gloom and doom, let's talk about a few things that we can do, some of the interventions that we can put in place that can help reduce these difficulties in accessing mental health services. Because it is a basic human right, really. It's not a favor being given to an individual to get mental health. No, it is the right. Health is the basic human right. Now, I like to look at things from prevention, because if we are able to prevent, then we are able to reduce the cost and the burden of care in ab initio. But the problem is that we wait till things deteriorate or escalate before we intervene. But that is not, that is not wise at all. So talking about prevention, we need to start from awareness. I started earlier by talking about poor knowledge, that many people don't access mental health service because they don't even believe that mental illness has a biological basis. So by the time we put in efforts in educating public awareness, it can go a long way in disabusing people's minds. So by the time they have this understanding, then it's now easier to intervene, to look at, okay, what are the biological causes of mental illness? Let us intervene. But it has to start from education, from people understanding that mental illness actually has a biological basis. Another way of intervening is by organizations, corporate organizations, schools, anywhere there is a collection of people pay attention to mental wellness. There are organizations that have signed up for wellness packages where they have trainings on stress management, striking work-life balance, anger management, how to interpersonal relationships, those things. Mental illness does not just come out of the blues. Yes, there are acute causes of mental illness, but there are certain background information that people have, lifestyle that they develop, that reduces the risk of mental illness. And even if the person will have a mental breakdown, the severity would not be as much as if the person had not done some of those earlier interventions. So if we are talking about physical health, we talk about exercise, we talk about diet and all of that to maintain health so that the person doesn't even have a breakdown. This is the same thing that can be applied to mental health as well, where people are advocacy on the dangers of drug abuse, going to even primary schools where it is incorporated in their mind what drugs are, the harm drugs can cause in the life of someone who uses them, going to everywhere to be able to educate people on what they need to do to be able to prevent having mental illness to a very large extent. That goes a long way to help. So prevention, advocacy, awareness, public awareness, education, by jingles, by, corporate organizations taking responsibility is a very good way to go about it. Now, another thing is, so even with education, stigma reduces. So by the time stigma reduces, people are able to talk about their struggles. People are able to, empathize with those who are struggling. In fact, you can have someone who would observe their neighbor or their family member, and something is off on with this person. Okay, let me support this person in going to the hospital. We taking responsibility for one another. So that education also helps to reduce stigma, so that people can come out on time to seek help, and then even support those who they have observed that need those help. Now, with the challenge with regards human resources is something that I think at some point, especially in the Southwest, they started incorporating, but I'm not sure how far they have gone with that. And what is that? Is about scaling up, mental health services, about incorporating it in primary healthcare settings. So the program is tailored towards educating the healthcare personnel in the primary health centers to be able to detect the mental health issues. For example, in centers where you have like
first increasing treatment by drugs use and
sorry, someone saying something.
Don't worry, I've removed the person. Please go ahead.
Okay. So so what I was saying is that one of the ways to be able to overcome the challenge with regards availability of mental health service, especially to rural areas and to semi-urban areas, is by having mental health team, especially if there is a tertiary institution there. The mental health team goes to these grassroots healthcare centers and train the healthcare staff, those who are in the employ of the hospital, those who come in as volunteers, to be able to identify common mental health conditions, anxiety, depression, things like that. And by doing that, they also make available medications, generic medications that they can dispense to these individuals. At least start by that intervention first. If it does not work, then there is a second layer of referral. In places where that has been piloted, it shows that the congestion of people from rural areas coming all the way to the urban hospitals for care reduced significantly. So you have early presentation. Because if I have a hospital that is not far from my house and I have a symptom, I don't keep it to myself because I'm thinking, how do I travel all the way? I will just walk into the hospital, get my complaints listened to, I'm giving medication. That goes a long way in early intervention. It goes a long way in making sure that people have access to healthcare service. And if there's any condition that is beyond their control, then they can refer. So the numbers of patients that they get to refer is not much. Even after referral, when the individual has been stabilized in the bigger hospital, they are sent back to the community and then care is continued from there. So that is what community psychiatry tries to achieve. And if we're able to incorporate it into our society, it will go a long way in reducing the challenge that people encounter in accessing mental health service. And the drugs are usually subsidized, so it's also easy to have medications that are needed for the healthcare service. Community, let me dwell a little on community participation. this advocacy education is not where we gather people, talk to them. We need to go to the communities. We need to tell them about, oh, when this person has this so and so symptoms, let the person go to the hospital. Community participation is very important, because once we have that, it makes it easy for people to have, for them to embrace the treatment. Because if you don't have that community participation, and you put all the infrastructure, the human resources and every other thing, there will not be patronage of the hospital. They will not be utilizing the hospital, because they don't really see the need of going to the hospital. So community participation is very important. And then funding. We cannot achieve anything without money. Funding needs to be more. We need to pump in more money into mental health, because all of these interventions need money. Training needs money, advocacy needs money, setting up the hospitals need money. Everything needs drives on funding. And it is not only governments that can do it. Donors in the form of NGOs, in the form of corporate bodies, in the form of common purse. There are some people who just come together, pool funds to be able to make money always available when people need it. There are different kinds of funding. So funding is very important to be able to drive these things to reality. Now, piecing all these things together, if we are able to, from here, talk to another person about mental health, that person cascades it to the other person and keeps spreading it. It reduces that idea, that belief that if you talk about mental illness, you're talking about the man on the streets who has lost his mind and is walking naked. No, it is telling people that as far as you have a brain, just as your leg can be sick and then you go to the hospital, the same thing can happen to the brain, that for some reason it's not working as it should, and you go to the hospital. I believe that one major problem we have in Nigeria is stigma. If we overcome that and we are able to make people embrace getting help, loving people who have mental health problems, caring for them, and accepting them into the community to be taken care of, it will go a long way in overcoming the other problems that we have. Because I don't think that we will ever get to the point where we have enough psychiatrists, we have enough clinical psychologists, psychiatric nurses, and other team members. I don't think we'll get to that point. But if we are able to have the community accept mental health care, then we can get people from the community, community health workers, nurses, to be trained to identify these problems and then to be able to put in their preliminary intervention. And then if there is need for referral to bigger hospitals, then so be it. So as an ending note, I don't believe that we should be problem-oriented. I believe that as we find out the problem, we should be able to focus on solution to those problems. So I implore all of us as advocates that in our little space, we should encourage people to speak and talk about their struggles. If you are a CEO, you should have wellness packages in your welfare package for your staff. You should encourage that people should seek help when when there's a need for it. As a CEO, you shouldn't sack someone because the person had a breakdown. Instead, to be supportive. If you manage a HMO, try to see how you can make mental health part of the basic care that people have access to. And I believe together, collectively, we'll be able to drive a healthier nation. Thank you so much, everyone.
Thank you very much, dear Dr. Abiola Burema. Dr. Abiola Burema is the consultant psychiatrist and mental health advocate. Thank you very much. I think you've indeed provided a lot of insights. One of my takeaways from your closing remark is the fact that in our own sphere of influence, in our own little corners, we should encourage everyone, people around us, whether at the family level, in workplaces, worship places, wherever we find ourselves, even in our social environment, we should encourage people to speak out and talk about their struggles so that they can be provided help. Once again, we'd like to appreciate you, Dr. Abiola Burema, for that insightful presentation. We would like to quickly acknowledge some of participants on the space already, like we often do. We may not be able to acknowledge everybody, but at least the few that we pick randomly. First, one of the first set of people to be on the space today is a senior member of the platform and a very strong ally in person of Dr. Abdullahi. Dr. Abdullahi is the Executive Director of Excel Mental Health Foundation. He is also a consultant psychiatrist at the Ahmadu Bello University, Zaria. Thank you very much, Dr. Abdullahi. Dr. Abdullahi will be speaking to us after this brief intervention now. We want to hear his own perspectives. We want to get some insights from him as well. I would also like to acknowledge Bubada is joining us from Rivers, Port Harcourt. I've also seen Namadi Adamu. I've also cited Pharmacist Agboma. Pharmacist Agboma was actually a guest on this space last week when she made quite a lot of insightful presentations. Also, we've also seen Ojedira Oluseyi, thank you. Farida Hazan, Hakim today, Abubakar Sadiq Haruna, Tola Adlinton, Dr. Jonah Kolo. Dr. Jonah Kolo is also an officer of the agency. I've also seen one of our regular blank mind, Olowude Sheyi. Dr. Ladega was also a guest on this space some time ago. Jumi at 360 Moa. I've also seen our own John Ogunjimi, one of my colleagues, Shedi Unduku. I've also cited him. We also have Bukola. I've also seen one of, I'll call her one of our regular, that's Tinu Idowu. Tinu Idowu is a medical personnel. She joins us from Maryland, USA. Thank you very much, TK. I've also seen one of my friends, that's Biodu Durojaye. Thank you for joining us. That will be all for now. I'll definitely acknowledge more people as we go where we have the space. Okay, let's quickly come down to, we have some questions in our DM already, but before we get to that, let's take okay, I think I just approved Dr. Barry Avotu Johnson. Dr. Barry Avotu Johnson, thank you for joining us. But let's quickly take some insights from Dr. Abdullah. Dr. Abdullah is of the Ahmadu Bello University Teaching Hospital. He's also an executive director at Excel Mental Health Foundation. Dr. Abdullah, last week I think we missed your contribution, but even though you were present on this space, but I think that's why you are trying to make it up this week. Please go ahead. Let's hear from you. Thank you.
Yeah, thank you very much, Mr. Femi Babafemi. Thank you to all our listeners. Good evening to everyone. Please permit me to recognize the presence of my teacher, my very senior person here, Dr. Nafisa Hayatuddin, whom I learn will be talking to us next week. She's with us here. I can see her profile in the listeners' corner. I wish she had made herself available to also talk to us. She is a very experienced senior colleague and a very good teacher. Thank you very much for joining us. So I would like to thank the presenter. She has done a very wonderful job. Like she said, I have very few things to say. Most of them she has already made it very clear. Access to mental health and drug addiction treatment is crucial for individuals struggling with these conditions. And like she said, however, there are various challenges that hinder individuals from seeking and receiving the care they need. And if we are able to address these challenges, it will improve access to treatment and ensure that individuals have the support they need to lead healthy and fulfilling lives. So some of these challenges, like she mentioned, include stigma. Stigma is, I think, in my opinion, the biggest barrier to getting access to treatment for drug addiction and mental health problems. So if we are able to reduce stigma, we could improve access to these very vital services. And how can we reduce stigma? We can do that by increasing our advocacy like we are doing here, public education campaigns, media portrayals that accurately represent mental health and addiction, and anti-stigma training for healthcare professionals and community members. All these can go a long way to reducing stigma, thereby encouraging people with substance use problems and mental health problems to seek help. We can also try to increase the availability and affordability of treatment services, like she had mentioned. You know, there is shortage or gross depth of mental health professionals and even facilities that are made available to provide treatment for individuals who are going through substance use problems and other mental health conditions. So if we are able to bridge this gap, we will be able to improve access, and that can go a long way. I think we can also promote telehealth. That is like what NDLA is doing. Not all these consultations should be physical consultation. We can actually reach a wider audience if we try to encourage this telemedicine where consultations can be done via either video conferencing or just normal calls and stuff like that. For those that are not very severe, I think we will be able to reach a much wider audience, and that can go a long way to providing access to people who would otherwise not be able to get access to these services. We can also integrate, like she said, mental health and addiction services into our primary healthcare system. I think we have spoken about this several times on this platform. The primary healthcare is the closest to the people, and every local government in this country have a primary healthcare facility. So if we are able to make those primary healthcare facilities functional, and we incorporate these substance use problems services and mental health services into this primary healthcare system, a lot of people will have access to these services. But as long as the pressure is on tertiary health centers and the few private health facilities we have, they will continue to be this problem of accessibility. You know, we can also improve access by addressing the social determinant of health, like poverty, lack of education, poor housing, and so on. All these things contribute to increased prevalence of substance use disorders and mental health problems. So if you're able to address this social determinant of health, it could go a long way to reducing the number of people who are having these substance use problems or mental health problems, and that can give us some breathing space. Another thing we could do is to train healthcare providers, like she said, to recognize and address mental health and addiction problems. Not every healthcare provider is trained in the area of substance use problems or mental health problems. And the number of mental health professionals is quite low in the country, very few. So there will be need to train the other healthcare providers on how to recognize, substance use disorders and mental health disorders, and how to provide some level of care. And like she said, for those disorders that are so severe that require expert management, they can refer appropriately. So if we are able to do this, that can really go a long way in bridging the gap of accessibility. We can also provide support to family and community members as partners in care. These community members and family members are very important people who play a vital role and a significant role in the care for individuals who have drug use problems and mental health problems. So if we provide them with the resources, to recognize and the challenges involved in drug use problems or mental health problems, they are able to know the red flags. They will go a long way in assisting in the management of these individuals. We can also promote peer support and self-help groups. If we are able to support people to form this peer and self-help group, those people that have had problems with addiction, they have been rehabilitated, they are now doing well, they can form a group to help people who are going through similar challenges. Usually when people are within their midst, the peer group, they'll be more open, to talking about their experiences and also learning from these people that have had similar problems in the past but have been able to overcome these challenges. This can also be a good way of, promoting access to mental health services. We can also address cultural and linguistic barriers. In most instances, when you are providing services that are not culturally appropriate to a person or a group of persons, the tendency to reject it is very high. So if we're able to deal with these issues, accessibility and acceptance will be very, very high. We can also advocate, like she said, for policy change to expand access to treatment. We can advocate to our policymakers to see substance use disorders and mental health problems as a very significant part of our problems. So, increasing budgetary allocation to mental health and other policies that can expand accessibility will go a long way to addressing this problem. I think these are some of the few things I have to say. Once again, thank you very much to the presenter for doing justice to the topic at hand. Thank you very much to all our listeners.
Thank you very much, Dr. Abdullah, always on point. I believe you already expatiated on what Dr. Abiola Bremer stated earlier. It's very great to have that insight from you again. Shortly between, okay, thank you very much. Okay, let's quickly, okay, your Dr. Abdullah already helped in fishing out or citing Dr. Nafisatu Hayatuddin. Dr. Nafisatu Hayatuddin is definitely, Dr. Abdullah already let out the cat out of the bag, but then we're glad. But then it's going to be interesting again next week by the grace of God, just as we're having quite a lot of insights now. Dr. Nafisat Hayatuddin is a consultant neuropsychiatrist at the Federal Neuropsychiatry Hospital, Banawa, Kaduna. She will be live with us on the space next week, and I'm assuring you it's going to be a very huge one. Okay, let's come back to the presentation by Dr. Abiola Burema. Now, thank you once again, Dr. Abdullah, for that insight. Okay, I'm not sure Dr. Bremer will want to speak on that. I mean, to that again, since he just more or less supported what you have said earlier, just adding some flesh to some things there. Okay, let me take this from somebody who was on the platform. He's been on right in a DM. I guess there might be some issues interpreting what and that is Peter Titiwat. That's he joins us from Thailand and is in our DM. Let me try and try to read what I believe he's doing Google translation. He just typed it, so quite a lot of things are mixed up. But then if it's something Dr. Brimo can respond to or speak to, fine. But let me read. He's saying, "Dear all, let me listen." Okay, you are talking about people who use drug-centric approach that's ongoing in Nigeria. Like I said, I guess because since he's not in Nigeria, he's a Thai. He's based in Thailand, so let's just try and make sense out of his English here. Obviously, he used Google Translation. As an outsider, as a non-Nigerian Thai person, Thailand, but as inside as a drug user, I guess he's a drug user. As a person with using drug myself, if I would say that what is the huge challenge that we're facing right now under my context, that's maybe he's talking about in Thailand, I will say the challenge he is facing, or what is his own challenge there, is government officers, police officers, as well as government personnel related. As I said, I'm a Thai person. I don't know how yours. Well, we're discussing our own challenges and how we can overcome all of those challenges. So I think he's just trying to give an impression of what the situation is in Thailand, where he is as a drug user. I think Dr. Abel, he is basically saying government officers, maybe police officers, maybe those who use drugs are arrested over there. So I guess that's what he's trying to say here. Why here we're providing help for them? He's just trying to make a comparison. That's what I guess he's trying to say there. Okay, Dr. Abiola, would you want to say something to that?
Okay, so we are still, caught between whether the criminalizing people who use drugs or sending them for help. But as a mental health physician, my stand is that addiction is a brain disease. Many people still believe that people who are addicted to drugs are just deviants, they are stubborn, they are the black sheep of the society, and all of that. But science has shown us that there are changes that happen in the brain where there is a compulsive, urge to use drugs. There are different reasons why people start using drugs. Some people start using drugs because their friends are using it. So under peer pressure, they succumb to using drugs, or to enjoy the party, for leisure. Some others use it as a form of medication. Oh, once I take this drug, I feel calmer, my stress is gone, I feel less anxious, it elevates my mood, or it makes me sleep. There are different reasons why people start using drugs, either drugs on the streets or prescription medication. But it now gets to the point where it is out of the control of the person. It's such that even when the person wants to stop using those things, they are not able to do it because there are changes in the brain already that has made it difficult for them to be able to, control the use. So when we're talking about drug addiction, I stand that we should move away from criminalizing people. We should move towards letting them get help. Because, okay, maybe they started off as, being problem children or problem individual adults, and then they found themselves in that situation. But because they have found themselves in addiction does not mean that we should lock them up somewhere. They actually need to be treated. So let me give an example. For physical health, if somebody, maybe by virtue of unhealthy eating, no exercise, just poor lifestyle, now develops diabetes, do we now say that the person should be locked up? No, we tell the person, I'll go to the hospital. So why should it be any difference for mental health? So, well, for what he has said, for what the person who gave that contribution, we should not, we should not be criminalizing people. Yes, as NDLEA is doing, clamping down on people who peddle these drugs, who are drug barons, yes. But when we now talk about addiction, we shouldn't go arresting them, locking them up. They should go to the hospital because there is a biological basis. And the thing about it is that it's not just that it's a brain disease. There are also treatments that has been shown to, to work. So it's not just that, okay, it is a medical condition. It's also, there is also treatment that can be instituted to help these people, come out as better individuals.
All right, thank you very much there, Dr. Biola Bremer, for your response to the contribution or question from our friend from Thailand. Thank you again, Pete Titiwat. Titiwat joins us from Thailand. He's still on the space. I hope he understands what you've just explained. Okay, I think I lost Rohit Gua there. Rohit Gua, I was about passing the mic to you, but you slipped off. Okay, let's give the next opportunity to Umar Daura. Umar Daura, can you unmute yourself? Let's hear your contribution or question. Umar Daura, please go ahead if you are ready. If you are not ready, I'll go to the next person or I'll move to our DM. Okay, if Umar Daura is not ready, let's yes, Gamboa Ayuba. Gamboa Ayuba, you are just joining. Okay, let's quickly give the next opportunity to Dr. Barry Avotu Johnson, the first. Dr. Barry, if you are ready, please go ahead.
All right, thank you. Thank you, Mr. Femi, Abi Chief Femi or Dr. Femi.
Thank you very much, Dr. Barry. Please go ahead.
Yeah, thank you. Yeah, I just like to use this opportunity to appreciate you for the opportunity you've given to Nigerians to at least liaise with you people and talk to you people, ask questions, those that are very far from the commission, and the privilege of also contributing to how the commission can improve. I was on this platform some months ago, I think just immediately after the elections or during the election or so. I was trying to ask a question, questions like I'm asking about the antics of the commission on the need to find solutions to the issues of political capture by drug offenders. Do you understand what I'm trying to say? How can the commission be streamlined in the drafting of electoral laws that must prevent drug lords from participating in politics and thereby infiltrating our leadership values. They are taking very irrational decisions that brings government very far from the people. Because in most countries now in the world, we confirm that drug money is used in politics, and most of these people who bring in drug money into politics, they capture the governance of whatever country they are interested in and put their people above every law or every act or every decision or every request by the people of that country. And we know how drug individuals behave. They can take any decision, policy, they don't care how it affects the people. So how can commission be given the opportunity to also participate in issues of screening of candidates before elections from in the National Assembly?
All right.
That's what I'm looking.
All right. Thank you very much there, Dr. Barry. I think this, you can mute yourself now so that you can hear me properly. All right. Thank you very much there, Dr. Barry, for, I believe what you're trying to ask, these are issues that we often, this does not, this has to do with the electoral process, and we believe that definitely the agency itself, we've tried to advocate for certain measures to be taken. And we know that, for instance, in Kano State, the Kano State government actually adopted a policy where there is a screening for those aspiring for political offices or those who are able to be appointed into offices. And all of these, I mean, these kind of people are made to go through drug integrity test in Kano State. That's under the last administration of Governor Umar Ganduje. That I'm very much aware of. And I think some way back since 2021, we also did advocate for blanket drug tests, not only for political office aspirants, but for students, job seekers, prospective couples, those who want to get married, all of those people. These are all part of the processes. You know, it's not a one-stop thing. Definitely, solutions, policies, ideas will continue to evolve as we develop our country, as we develop our democracy. I will believe definitely that we will get there one day. We're getting there already by the grace of God, and we would ultimately resolve all of these issues, especially as we try to prevent those who may be on drugs, especially starting from not necessarily at the highest level, but even those that are the grassroots, starting from councillors, local government chairmen, all of these, the agency had explained have been issue. I'm talking of way back 2021, and we'll continue to do that in the interest of our country. Thank you very much for your contribution. We move quickly now to our DM, Dr. Abiola will have some questions in our DM here. Some of them you might have answered, but then if you have answered them, just go through them over and over. Just brush it again so as to satisfy or meet the needs of the people sending the questions. I think this one, how can the less privileged, especially very low income earners, get access to treatment and rehabilitation? Okay, that is okay. Let me allow you to answer that before I move. I have about 6 here waiting for you. Okay, so you can take this first, then I'll come back to you. Thank you.
Okay, so thank you, sir. I'm going to answer that on 2 layers. The first is that what the current situation is that, like I said earlier, we don't really have the presence of mental health service in communities. When I say communities, I'm talking about our primary health centers. So at the moment, the best the person can do is to go to the closest hospital, government hospital. Now, where I did my residency, the hospital was located in a rural area, though it was though it's a federal hospital. So we have majority of our patients come from the rural areas around that hospital and neighboring states. And they did it in such a way that there is a hospital purse that staff commit certain amounts every month to be able to support people who come to the hospital who don't have money. And then also there's an Islamic, sorry, I meant to say religious body that have an endowment fund that also helps in supporting people who don't have, who cannot afford to pay for their bills. So the current situation, what I would say is that the best they can do is to go to the nearest government hospital to access health care, and hopefully they get to the kind of hospital where I did my training, where people who are not able to foot their bill can have that support. However, in the long term, we would need to keep encouraging government to look into training people in the community to be able to meet the needs of people who need mental health care, even from the community, so that they don't have to go all the way to town or to another state to be able to get that healthcare service. So I believe that the question was with regards how someone that stays in the rural community currently can get healthcare service. So the best I can just say is that they can, ask questions about where the closest hospital, government hospital is. Most of the general hospitals, FMCs, teaching hospitals, and then fortunately, if there's a neuropsychiatric hospital there, they can get mental health service there.
Okay, let me quickly. I think the question is low-income earners get access to treatment and rehabilitation. That's not even about. I also think yeah, you want to say something on that?
No, go ahead, sir.
Okay, I also think in addition to what Dr. Abiola said, we, as part of the agency's advocacy across the country, we were in Borno State for 4 days this week, and I know part of the things we're pushing is also for state governments and other stakeholders to, even in our visit to Delta State about 2 weeks ago or so, this was also part of our discussions with the relevant authorities, especially the state government, to see how the primary health, the personnel of the primary health care level can be trained to be able to respond to some of these issues of substance abuse and mental health issues, so that at that point these people can get immediate help. And when it goes, just like Dr. Biola said earlier, when it goes beyond their capacity, then they refer to a higher institution. That is, but then just to ensure that we don't leave the grassroots bare. And this is also part of the reasons why the agency in the early months of next year would also be deploying to our personnel to the local government level, so that we can bridge this gap and get work with the primary health centers across those areas to be able to bring help to those who need help early enough, especially those who would need help early enough and they don't actually know what to do. And that's part of the reason, again, why we also provide toll-free helpline where people can call from anywhere, no matter how remote such community, as long as there is telecom service there, so that they can also talk to experts, ranging from counselors, psychologists, psychotherapists, and psychiatric doctors. All of them work 24/7 at our help center, at our call center, where they can also provide these basic services before things get out of hand. Okay, let me get one again from our GM, Dr. Abiola. I think it's someone on the space also. Okay, that's Jumi at 360 Moa. Is asking, how effective will you say rehabilitation is for drug users, considering the number of people who relapse after some time of rehab? Okay, that's for Jumi at 360 Moa. Okay, you can go ahead, Dr. Biola.
I'm so sorry. I had a problem with my connectivity. I didn't get that question.
Okay, Jumi at 360 Moa is asking, how effective will you say rehabilitation is for drug users, considering the number of people who relapse after some time of rehab?
Okay. Okay, the truth is that rehab is, the success rate of rehab depends on so many factors. You have individual factors, you have the support system factor, you have the treatment factor, you even have the kind of drug use. So there's a lot of factors that determine how effective rehabilitation is. So, but because there is also high relapse, I mean, it's a chronic relapsing disease. We don't deny that. So, because it is a relapsing disease, also does not mean that we shouldn't intervene. Because the more you have interventions, a lot of times, the more that, okay, there is a chance that you finally have success. And for every time that person is in a rehab for treatment, you have at least broken the cycle of drug use and then have the body to, recover and given a fighting chance. So it is not it's not an unknown fact that a high number of people who use drugs relapse. It's a chronic disease, but it still shouldn't stop the fact that if there is at any point in time, if there's an opportunity for rehabilitation, for medical intervention, let's give that person that opportunity to be able to come out of that situation. I hope that answers the person's question.
Definitely, I believe that Gambo. Until we invite you to speak. Thank you.
I can step in.
Appear like it's purely Nigeria. Let me go to the diaspora members. Let me go to Dr. Loretta Ekanem. Loretta Ekanem is joining us from Chicago, Illinois. Loretta, you are back to space today.
Good morning, sir. Good morning, everyone. Good morning.
We are already in the evening here.
Sorry. I'm so
sorry. Difference now. Yeah, I know. Just to let you know that we have majority who are in the evening here. Thank you. Please go ahead.
I'm so sorry. Good evening, everyone. Good evening, Nigeria. Good evening, my people. I'm sorry I also joined late. Dr. Abiola, well done. I hear you. I just wanted to make a quick contribution about reasons why people relapse after they've been to the rehabilitation centers and they go back. Now, the truth is, one, this might not be familiar with us in Nigeria because our approach in Africa generally and our approach generally all over the world, not just Africa, is abstinence or treatment. Either they abstain from using drugs or they actually go to a rehabilitation center to get themselves detoxified and stay clean and come out clean. Number one, for substance use, there are different kind of reasons. There are baseline reasons for why people use drugs. And the drug effect or the harm associated with the use of drug and the treatment of those effects is just a surface, it's just responding to the surface and not to the roots problem. And so you see people, they go in and they go back and they're like, it's worse than they started. I will cite an example. I know someone who was clean for about 15 years, clean, went to the center, came out clean. The moment he used an opioid again, he couldn't stop. And that led to his death, unfortunately. So you can imagine someone that have actually stayed 15 years and went back and died. It means the root cause was not somewhat really addressed. So what we normally do is cut the branches and cut the trees and the leaves, but we do not uproot the tree. So what are the root problems? People, places, and things. Somebody comes out of the rehabilitation center, goes back to the same people that made him or her start using drugs. Go back to the same thing that triggered the use. Go back to the same place that triggered the use. Now tell me, how will the person be whole at the end? So this is why it's actually, like Dr. Bello said, Dr. Abiola said, it's a joint effort. Once you have family, friends, whoever goes into the rehabilitation center, you must also prepare the environment the person is returning to. If I go back to the friends that made me start using drugs, I still do not have that willpower. Because when you are in a secluded place with a cohort of people that you're working together to achieve a purpose, once you come out to the larger world, you might not have that strength or willpower to overcome it. So this is where family comes into place. Doctors can do their bits, but family, friends, neighbors, community also have to do their bit. Do not take the person back to where the whole problem started. Do not enable them to have access to the use of drugs. Do not allow them to be with the same people that they were with when the whole thing started. Take them somewhere far. Let them really adjust to a new environment. I've had a couple of interviews in a couple of research, even in Africa, where people say that immediately my son got out, I took him out. I had to move us out of where we used to live to another place. Now the question is that how are we sure that the other place wouldn't be infected with people that could influence him, or her to begin to use drugs? But a new environment, he begins to a somewhat large extent, begin to adjust, imbibe, and apply all what the person have been able to go through in the rehab homes. So that's to answer the question. Another one, so I don't take all our time, is what we call harm reduction. And that's why I said it's not applicable to just Africa. Even in the Western world, people are fighting what we call harm reduction. People think when we say harm reduction, you're enabling people to use opioid. It is not true. You could ask yourself, when you were all kids, when your parents tell you, go and wash, go and do stuff, sometimes you want to do it when you are ready to do it. It might not be the best approach, but sometimes we force people, we force them to do what they are not ready to give up. Between the time when they are ready to give it up, we need to provide an avenue, a channel where we can keep them alive and help them to thrive in the community. And that's what we call harm reduction. And what are the harm reduction strategies? I know Dr. Babafemi would not want to hear this. If people must use drugs, can we have safe consumption sites where people are monitored by professionals? Can we ensure that they have clean syringes so they don't get other harm diseases that comes from the use of needle exchange? Can we ensure that they have Narcan to reduce overdose and all that? So it's all so big and wide, but just to narrow it down to the question, we have a part to play to ensure that once people are out of the rehab, they do not go back to people, place, or things. Thank you.
Thank you very much, dear. Dr. Loretta joins us from Chicago, Illinois. Thank you very much, Loretta. Dr. Abiola, would you want to say anything to that? We should move to the next contribution.
No, I think we can move on to the next one. Loretta really, she explained explicitly and gave a lot of insight into some factors. And I mean, she has done a lot of justice into, explaining other aspects that can make people relapse. So I think we can move on so that we can accommodate more questions.
All right, thank you very much. I was wondering why Loretta's network didn't fail today. Well, I don't want to go to that aspect, so that it doesn't appear that it's only our network in Nigeria that has some glitches sometimes. Thank you very much again, Loretta. Okay, let's take the next contribution from Asma Ahmad. Asma, I think this should be the first time. Asma is a constant face on this platform, but I guess this should be the first time she'll be speaking. Asma, go ahead.
Good evening, Dr. Babafemi. Actually, this is not my first time. I think I spoke 2 months ago. Well, good evening, Dr. Babafemi, our host, Dr. Abdul, Dr. Abiola, and every other listener on the space. I'd like to throw a question to Dr. Abiola. Earlier, she made mention of passion in mental health and shortage of mental health experts. I would like to ask if individuals who are not medical experts or health experts gain access to training on mental health, or officers of the National Drug Law Enforcement Agency, or private individuals who are stationed in drug demand reduction departments or rehabilitation centers, so that they could also contribute their own quota to communities around them. Thank you.
Okay, so Asma, sorry, I'm not sure I got the question. It sounded like a contribution to me.
Okay.
No, she actually asked a question.
Okay.
Okay, I'll take it again. I would like to ask if individuals who are not medical experts or health experts gain access to trainings on mental health, especially officers of the National Drug Law Enforcement Agency, or people, officers of the National Drug Law Enforcement Agency who are stationed in drug demand reduction departments or rehabilitation centers across the state. Can we have access, or can they have access to mental health trainings?
Okay, yes. So remember when I spoke about people in the community, if we want to have community participation and then incorporating mental health service into primary health care. I said that people who are CHUs, that's community health extension workers or officers or the nurses or even volunteer health workers can be trained to be able to identify these common symptoms of mental illness. So if those people can be trained, even people who have interest can be trained. The only thing is that people should be able to understand their limits, to be able to understand their boundaries. Where we have problems a lot of times, especially in Nigeria, where regulation is not enforced, is that people go, they cross carpet into aspects that they don't have expertise for. So it's very good that people get these trainings so that they can know how to do like psychological first aid, for example, is what people can, learn how to do, so that on the field, if you have need to, support someone who is going through trauma or has experienced something very devastating, you know what to do. You are able to intervene before you now, if there is need for, further care, push on the buck to the next level. So yes, people should be trained. People should have, skills, should develop skills and expertise in supporting the mental health space. but should be able to just know, okay, this is where my limits are, and be able to know where, to be able to know the next level to refer people to. I hope I did justice
Absolutely.
to your question.
Absolutely. I also think it's something I also mentioned in my intervention shortly before Asma asked the question, that this is also part of the reason why the chairman of the agency, General Marwa, is having a lot of engagements across the state with stakeholders so as to get the primary health care centers involved by providing training for the personnel at that level, at the grassroots level, so that they can be able to do some interventions at their level. First layer intervention, and then they also have to also know where to draw the line, so that when they have to refer to the next level, they will know what the signs to observe or to note before they refer somebody to the next line, but at least get them involved at that level. Thank you very much once again, Dr. Abiola. Thank you, Asma, for coming up with your question. I have, I know Dr. Kemi Lawyer will take some 5 minutes, so let me quickly grant SDG3. SDG3 has been raising his hand since. Please, SDG3, let's hear your intervention or question within 10 seconds. Please go ahead.
Good afternoon, everybody. Please, my question is really straightforward. I would like to know the cost of, if, for instance, you want to independently sponsor someone in an addiction recovery program, how much is it going to cost and what is the duration? I'm asking this question because I know that part of the WHO guidelines for committing someone to a mental health facilities, you have to get their consent and make sure they know they are making an informed decision. So how much would it cost and what is the duration of an addiction recovery program? Thank you.
Thank you, SDG, for that brilliant question. Let's get from Dr. Abiola.
Okay, so with regard to sponsorship, I think the best way to go about it is to either approach an organization or hospital that offers that care and then ask for how much their service, how much the cost of service is, because it's not a blanket cost. Even within the government space, different hospitals charge differently. So it will be difficult to talk about or to put a figure to it. But in literature, for rehabilitation, it's a minimum of 90 days. So duration also is very difficult because treatment is usually individualized. Yes, it's been studied and shown that people who stay for more than 13 weeks do better than those who stay for shorter duration. But then it is not cast on stone. Someone can might need rehabilitation for much longer than 13 weeks. So it's very difficult to answer your question because it's not fixed. So the best way is, if you have any hospital in mind or any organization that gives this service, you can approach them and then decide that, okay, I want to be a donor, I want to be invested in the recovery of somebody, and I'm sure they'll be able to talk you through all that is required for that.
All right, thank you very much, Dr. Abiola. I think that's explicit. Okay, let's, Dr. Kemi, we have just barely 10 minutes. I know you are a late comer, but then please just do all you have to do under 2 minutes so that we can still get a lot of people to participate. Thank you very much. I know you are joining us from outside Nigeria.
Yeah, basically what's going on is that sobriety is the name of the word. I was here for 18 months And I left the NDLA spaces August 28th, and I said it that this year, even though we have 3 months left, sobriety is coming in. Naira Marley came into the NDLEA, and a lot of people were wondering what happened, why. It's the same question around the world. You don't know if any of the former drug users are going through sobriety. And sobriety is when they just decide one day, I don't want to smoke anymore. So we have Naira Marley, and then last night it was Snoop Dogg. The situation with Snoop Dogg is, and I was there from the beginning in the 90s, Snoop Dogg started smoking marijuana as a prescription for his glaucoma. If you notice his eyes, they look very like thin, like he has suffered glaucoma for most of his life. So at that time in the 90s, we ourselves, when I say we ourselves, I myself was dispensing marijuana in synthetic form at Johns Hopkins Hospital while I was the outpatient pharmacy director there. I also worked in the inpatient. Marijuana has medicinal uses. But when you say that today, that marijuana has medicinal uses, why can't we legalize it in Nigeria? It's not the marijuana they're smoking in Nigeria. If you go to Ghana, the marijuana they want to legalize in Ghana is for medicinal purposes. So now everybody's scrambling to be a grower because the people growing will be able to sell. So we have all these Ghanaian rappers who want to start marijuana farms. They're not giving them licenses. It's a different kind. It's not hashish. It's not kush. Marijuana is totally different. Now, talk about medicinal marijuana really quick, 2 minutes. When you have somebody taking any medicine, marijuana or not, people that have been taking hydrocodone, oxycodone, narcotics for their pain, after a while, they become addicted to the painkillers. And they have legal stuff they're using it for. We have seen a lot of people go addicted, and there's so many lawsuits in America, blaming pharmaceutical companies for this kind of stuff. So Snoop Dogg went from smoking marijuana and then culturizing it. I don't know if that word exists, but turn it into a culture, like glamorizing it in music, glamorizing it as a culture. Young people started smoking. And one young man, if you look on this Twitter account I'm using, I'm no longer on Twitter. I closed the whole thing. Twitter and TikTok, I don't need them anymore because in less than 30 days, in less than 90 days, I'm going to retire from journalism, February 1994. So that's 30 years. Closing these accounts. But anyway, if you really look at the way things were with Snoop Dogg, he became very, very busy promoting marijuana, and then it became a culture. And one young man followed him, Wiz Khalifa. I took some of Wiz Khalifa's tweets. If you look on this account I'm using, you'll see the tweet I'm talking about because I posted it on there. You can see how it says weed hangovers are real. And I answered him. I said addiction. Why do I answer all Wiz Khalifa's tweets? Because I once promoted his music for Warner Brothers, the record label. So I also have a music publicist degree. So I was his publicist when we were in Canada. Wiz now made what Snoop Dogg was doing even more popular. So everybody was smoking. At any one time, go to Wiz Khalifa's Twitter. It's all about weed, weed, weed. Then came Burna Boy. I also posted Burna Boy's tweet in 2013. Please go and look at the tweet. It's on this handle right now. 2013, Burna said, I quit smoking and I hope it stays that way. Today, Burna has a cannabis brand. He rejected $5 million from Dubai to perform because he couldn't smoke. What happens when somebody says they've quit smoking and they hope it stays like that and they continue smoking? Today, it's a little different. And this is where I end my speech. Stanford Medicine, Harvard Medicine, all the researchers have now found a link between marijuana and heart disease. Heart disease is...
Thank you. Thank you very much, Dr. Kemi Lawyer. Thank you. Thank you very much, Dr. Kemi Lawyer. Dr. Kemi Lawyer, until she started preparing to retire from everything, was a very senior member and very regular member of this platform. Thank you very much, Dr. Kemi.
Thanks for having me again. Thank you.
Thank you. Okay, Dr. Abiola, we just have barely 5 minutes. Let me quickly take, if you have a pen there, Dr. Abiola, you are most likely going to take 2 questions together. So please note these 2 questions so that we don't miss the opportunity of giving these people the chance of hearing something from you. One is, okay, what is the difference between treatment for drug addiction and treatment for mental health disorder? That is one. Did you get that, Dr. Abiola?
Yes.
Okay, the second one is considering the prevalent high cost of living, what do you think can be done to make treatment affordable for the lower class caught in the web of substance abuse? So those are the two questions I will take. I still have more in idea, but I think let's limit ourselves because of time to those two questions. Please go ahead.
Okay, so the difference between substance use or addiction and then mental disorders. Now, mental disorders is like an umbrella where you have different things under. Substance use disorder is a type of mental disorder. You have other conditions like depression, schizophrenia, anxiety, and a host of others. Now, substance use disorder can coexist or comorbid with other major conditions. So it's not as if they are different things. You have a mother or a big umbrella, and then you have things under. Now, the approach for substance use disorder is different from the treatment for schizophrenia, is different for the other conditions. So it's just like saying that you have a physical condition. Malaria is there, typhoid is there, cancers are there. The approach differs. So putting them together is not, I just needed to, give that clarity that mental disorders is a big umbrella, and then you have substance use disorders. Even under substance use disorders, you have different psychoactive substances, which their approach to can be different. Yes, there can be common interventions depending on the presentation. However, the intervention is based on what the person is presenting with. The treatment is individualized. So one is actually a bigger umbrella, and then the other is a type of mental disorder. Now, with regards to making treatment affordable for people, especially in this difficult situation, it takes collaborative efforts. Now, I had said earlier that as corporate organization, if you, for example, you head a corporate organization, it can be an avenue to, have a welfare package that employees can key into it, where if they have mental health conditions, there is a welfare package where they can be able to, get medical help through HMOs too can also come in to make it easier. So insurance can really help. Corporate organizations can drive insurance, their HMOs, to be able to ensure that mental health is available even from the most basic package. I would keep encouraging governments to make this mental health service available to people around, because usually with government facilities, health services is usually affordable. And then people who are more buoyant can decide to, sponsor people who have mental health problem. We just heard of someone who was, thinking of donating some funds to help someone who is less privileged. So if you have some money, you can go to the hospital, help foot somebody's bills. And then there are so many time. I see that time is not on our is not our friend right now, but these are some of the ways that we can intervene to make health service available to people who are not able to afford it.
Thank you very much, dear Dr. Abiola Buremo. Dr. Abiola Buremo has been with us for the past 2 hours, and she's giving a good account of herself, just like I said to our guest last week. Thank you very much, Dr. Abiola Brema. Dr. Abiola Brema is the consultant psychiatrist at SNAPSI Azalea Abuja. She holds a master's degree in public health from Ahmadu Bello University. Well, let me not jump her initial MBBS degree, which she earned from the University of Jos in Plateau State. She also holds a master's degree in public health from the Ahmadu Bello University, in addition to other certificates she acquired from the University of Washington in the U.S. in leadership and management in health epidemiology and project management. She currently serves as the clinical director at SNAPSI Azalea, a treatment facility within the Intersect Consortium. She is a mental health enthusiast and advocate. I actually know that indeed the agency has a partnership, as the NDLA has a partnership with Intersect Consortium because of their excellent services there. Thank you very much, Dr. Abiola Brema, for your time with the space. Dr. Abdullah is of the University. Aliyu Abubakar, my own camp patriot. I'm sure wherever she is, she'll be eyeing me like this. Okay. Thank you, camp patriot, for not being troublesome on the space. Well, no, camp patriot on this space. She knows where she's. She makes some troubles out there. Thank you very much, camp patriot. Babangida Buhari, SDG3. Thank you for that brilliant question. John Oluwole Ade actually asked. Okay, I think he just gave information. I saw his message in our Hello, dog. I'll attend to that later. Muhammad Bafo, Muhammad Abdul Kadir, our own Parabawa, Ima Obumbada, Namadi Adamu, pharmacist Agboma. I was actually a guest last week, and she equally gave a good account of herself. That was an excellent one last week on the space. Ojediro Oluseyi, Farida Hassan, Akin today, Abubakar Sadiq Haruna, Tola Adlinton, Dr. Jonah Kolo, Blank Mind, Olowude Sheyi, Dokita Ladega, thank you. Jumi at 360, I think Jumi also asked another brilliant question. John Ogunjemi Shidi Unduku, Adaize Bukola, Tino Idowu. Tino also joined us from Maryland, US. Biodun Durojaye, Dr. Nafisat Hayatuddin, who will be our guest next week. And next week, maybe I should give an expo on what we'll be discussing on the space next week. Next week, I think we'll be discussing family-based prevention and support in substance abuse and mental health treatment. Yeah, I think we'll be putting a focus on the family next week in this situation. Thank you very much, Dr. Nafisatu Hayatuddin, Umar Daura, Pete Titiwat joined us from Thailand. Dr. Loretta Ekanem. Loretta joined us from Chicago, Illinois. Thank you, Gambo Ayuba Pwakana. I'm sure Gambo is from Plateau State. Lara Ekoff, I was almost yielding the mic to her when she went off. Thank you, my own Asma Ahmad. I also saw Rohit Gua. I guess Rohit Gua also joined us from another part of the world. Thank you very much for all of you that have been part of this conversation today. Next week promises to be another exciting time. But before I go, let me quickly acknowledge some of my colleagues who have been working behind the scenes to support me. Shidi, Musa, Francis, Dele, Mahmoud, Blessing, Vina, Kumbi, Charity, Val, John, Ali, and Ima. Thank you guys and the rest of you. Definitely we'll do this again together next week. And at this point, I'd like to step aside. But before then, let me advise us, please, it's Friday. There's always a thank God it's Friday mood. Please, let's watch what we do. Let's be more careful, especially when it comes to what we consume. I'm talking of alcohol. Alcohol is a drug. Please, let's note that. And for those, the young people also, let's also be careful so that we're not on the wrong side of the law. Let's appreciate the fact that we have to stay healthy to be alive. Before I go, let me hand you over to Mahmoud to formally draw the curtain on today's program. Do have a wonderful weekend. Bye-bye.
Thank you very much, sir, the host, and of course, the NDLEA's Director of Media and Advocacy for guiding us throughout today's program. Before we go, our listeners who are enthusiastic about the agency can visit our social media handles at NDLEA_Nigeria on X, Instagram, and YouTube. On Facebook, it is at NDLEA01. You can also visit our website, www.ndlea.gov.ng. Do join us same time next week for another edition of this wonderful program. Over to you, Bamidele.
Gutter water handle you go just die throw away. When they handle you go just die throw away. Ecstasy handle you go just die throw away. When they handle you go just die throw away. Drama handle you go just die throw away. When they handle you go just die throw away. When cocaine handle you and codeine handle you when they handle you go just die throw away. When Black Mamba handle you and Ref not show you shade it. When he handle you go just die throw away. No, mama, no wait until them handle you. When they handle you go just die throw away. Paradise, Mr. Metro. When them handle you go just die throw away.